So all the presenters have nicely presented. Just carrying forward from so what Dr. Sunita and Dr. Vamshi has said. So there's a special entity in esophageal cancer which is locally advanced unresectable cancer. So these patients are especially treated by definitive radiation, but the outcomes are very poor in this. So what is coming now is after the results of Cosmos trial, which has so they have taken 48 patients of locally advanced unresectable, that is T4B patients, or with a fixed supraclavicular lymph node. So they gave 3 cycles of DCF-based chemotherapy, and they assessed for conversion therapy. So out of 48, half of the patient, that's 19 patients converted. Then they treated with chemotherapy. Chemoradiation. So they give total of 5FU cisplatin-based 60 grays of radiation. So the first assessment was done at 40 grays of radiation. Then again, so a few patients become conversion, and then after 60 grays of radiation, they again went and suffer conversion surgery. So a total of 21 patient went into conversion surgery, and they showed that the outcome of those patients who underwent conversion surgery after induction chemotherapy and after chemo radiation was 72% 3-year survival when compared to 42% for the overall group. So with that, the Japanese has started a randomized control trial, which is still accruing the patient. That is GCOG 1510. That is triangle trial. So with one group is receiving DCF-based chemotherapy followed by conversion surgery, and those who are unfit for surgery will receive definitive chemoradiation, and one group is definitive chemoradiation. So that is the evolving area in locally advanced unresectable patients.
Wait, hold on. So we have discussed only the common scenarios where the evidence is good. So the upcoming things, once those evidences come, next time we'll have a conference, that time we'll discuss. Okay?
I think I have just passed through that slide. Neoadjuvant chemotherapy is the way forward. I think I was just trying to show that. And probably we are also having trials with neoadjuvant immunotherapy also. So that's what sir was trying to say. Whether we'll be going, even sending the patient for surgeon is a question in the future. So neoadjuvant chemo immunotherapy and radiation. See the response and go.
Locally advanced cancers, 60 gray, and put them up for salvage surgery, it will be very difficult, both for the surgeon and for the patient also.
But you should not close the door on these patients. The fear of post-radiation has always been there. The fear is slowly coming down, but if you need some of these patients to live, you have to have a surgeon who adventures, not adventure. So it's important to save this component. See, if multidisciplinary, all of us come together, it is this groups of patients who need to be pushed into good quality and good quantity life. And these subsets are a challenge, and we have to pick up this challenge. Is it not? That should be the message. It's not treating patients who are potentially treatable and curable different way, but the ones who are not in this bin have to be brought into that bin. It's also important.
Yeah. Also, we had this discussion yesterday in the sessions. Also, like we are looking at a very small group of patients who we are not very sure. Yesterday, I think when we were in the local advanced gastric cancer, we were discussing that there are some patients who show very good response, excellent response to the neoadjuvant, and there are some who do not show any response. So for those small group of patients only, which are actually requiring a very aggressive neoadjuvant followed by surgery, and also then adjuvant therapy. And also we still do not have any way of preoperatively or postoperatively post-therapy assessment of the N status. All the assessment we do post neoadjuvant therapy, either chemotherapy or radiotherapy, to assess the tumor response is only for the T staging. We do not know N. And if we leave these patients after having achieved a T0, say from a T2 or a T1B to T0 post therapy, and we think that the tumor is off, but we have not assessed the N for these patients. These are the patients who have a very high chance of coming back with a nodal recurrence whom we have left out. So do we leave all these patients, which may be a small chunk now, but when they actually recur, they will end up being a bigger numbers out of this group of patients who are in the early cancers?